The last lecture in the hemodynamics series is hydrostatic pressure. Hydrostatic pressure is the weight of the blood pressing on the vessel measured at a height above or below the heart level. We measure hydrostatic pressure in units of millimeters of mercury, or mmHg. This may look familiar to the blood pressure that you get when you go to the doctor's office. When they are measuring your blood pressure at the doctor's office, they are getting your measured pressure, which is going to equal your circulatory pressure plus that hydrostatic pressure. When a patient is laying down, we consider them to be supine, or flat on their back. When the entire body is at the same level of the heart, that hydrostatic pressure ends up being 0 millimeters of mercury, because everything is at the level of the heart. Hydrostatic pressure comes in when there is a difference of levels of the body. So when we go above the heart, we're going to have negative pressure, or a decrease in pressure, and if we go below the heart, it's going to be an increase of pressure or positive pressure. So that is to say, when a person stands up, that the entire body is going to have different measured pressures. That is because with hydrostatic pressure, columns of fluid are going to have weight to them. For blood, we measure it compared to the level of the heart. Hydrostatic pressure is position dependent. If the patient is supine, the hydrostatic pressure is going to be 0 throughout the whole body, and if they're upright, it'll be negative or decreased above the heart, positive or increased below the heart. So let's look at our supine individual. At the level of the heart, we have already read that this will be 0 millimeters of mercury of hydrostatic pressure. If I was to look at the head, it is also at 0, the waist is at 0, knees are at 0, and toes are all at 0 because they are all on the same level of the heart. That all changes that when we put the patient in an upright position. We still have 0 at the heart. Because there is less gravity or less fluid stacked upon itself in comparison to the heart level, the head will be a negative number. We'll say negative 10 for the sake of ease. But as we travel below the heart, we're going to get positive numbers. So maybe this is a positive 10, positive 30, and a positive 100. Pressures are going to increase as we get down towards the feet because there is more weight stacked upon itself, and they are going to decrease the further we get away from the heart going up because there's even less blood stacked upon itself. When we take blood pressures at the doctor's office, think about how you're sitting there. They usually do it on your arm at the level of the heart. That's because this technically should be the true pressure that's going on in the heart. We also need to consider what measured pressure equals, and that is going to equal hydrostatic pressure plus the circulatory pressure. So let's go back to our example of our standing up person. Say his circulatory pressure is 100, and we're just going to use the top number for this example. So his circulatory pressure is 100. At his feet, his measured pressure would be 200. At his knees, his measured pressure would be 130. At the waist, it would be 110. At the heart, it would be 100. And then at the head, it would actually be 90. And that is for this standing individual. If we look at our supine individual, if his circulatory pressure is 100 and his hydrostatic pressure is 0 throughout, that means the measured pressure is going to be 100 at every level of his body. So breathing and venous flow could have gone into the venous hemodynamics lecture, but it also kind of has to do with pressures and how they change within the body. So it fits well into the hydrostatic pressure as well. So for that purpose, we're leaving it within this lecture. Breathing has a strong effect on how blood returns back to the heart via the veins. And that is what results in our phasic flow. And it changes how the flow accelerates and decelerates as it travels back to the heart. So with normal breathing and venous flow, the venous flow is going to be affected due to two factors. That the venous system is a low pressure system, and that there is going to be variability in thoracic and abdominal pressure. When we take a big breath in, our diaphragm moves down, and because of that, the pressure in the thorax decreases. When the pressure in the thorax decreases, we're going to have more flow from the head and the arms. Also with inspiration, because of that diaphragm moving down, it is now going to increase our abdominal pressure. And with that increase in abdominal pressure, it's going to stop or reduce the return of flow from the legs. The opposite is true then when we exhale, or during expiration, the diaphragm is going to move back up into the thorax, which causes increased pressure in the thorax and will decrease the return of flow from the head and the arms. Opposite of that then, the abdomen will decrease in pressure, meaning the return of flow from legs. So let's review again. In our first side, we have the diaphragm moving down because we're breathing in. As that diaphragm leaves the thoracic cavity, it creates more room, therefore decreasing the pressure. It moves into the abdominal cavity, which causes more pressure. Because there is less pressure within the thoracic cavity, blood flow can return quicker from the head and from the arms. The venous flow returning from the legs, though, is going to hit the abdominal cavity and stop because there's too much pressure for that blood to continue. As the person exhales, the diaphragm is now moved into the thoracic cavity, making it smaller and causing a positive pressure shift, and has made the abdominal cavity bigger, making the pressure less. This means now that as blood from the head and the arms comes in, it's going to hit the thoracic cavity and stop, but blood flow from the legs will be able to continue through because of the lower pressure. This back and forth of breathing is what causes that phasicity to show up in our waveforms. This chart should help to remind you of how pressure changes within the thoracic and abdominal cavities and what blood flow will increase or decrease from which areas of the body. Make sure you understand these charts and are able to explain it to a friend or explain it to yourself in a way that you will remember what's happening. So when we think of venous phasicity and how we see it on our Doppler waveforms, it's going to look very similar to what we're seeing down here. We're going to see some sort of forward flow and then a cessation of flow, either during inhalation or exhalation, depending on where we are in the body. We can see it rapidly if it's matching up with quick breathing. We might see it a little bit slower if the patient is slowly breathing, or we might see a change into steady flow. In this instance, the patient is neither inhaling or exhaling, but rather just holding their breath. So there's no change in how that waveform looks. So again, if we have a patient and we are sampling the flow within their arm and they take a big breath in, the thoracic cavity is decreasing in pressure, meaning we're going to get a lot of forward flow. As they exhale, that flow is going to stop. When they breathe in again, more forward flow, exhalation, it'll stop again. That is phasicity in the arm. However, if we were down on a leg and we were sampling down in that leg, as the patient inhaled, it would stop. Exhale, the blood flow would move forward again. Inhalation, it would stop again. Blood flow would move forward again on exhalation. So in legs, it stops on inhalation and moves forward on exhalation. In arms, it's going to move forward on inhalation and stop on exhalation. It all has to do with those variances of pressures in the thoracic and abdominal cavities. So this is going to be more one of those concepts that you're just going to have to memorize or try to figure out, when you take that big breath in, think to yourself, where's the pressure? Think about why air is going into your thorax. When you take a big breath in, you're decreasing that pressure and air is just getting sucked into your lungs. That's how all of that works. So think it through. Think how those pressure changes and how the blood flow is going to be returning back to the heart because of it. Also with hydrostatic pressure, the big thing to remember is that the level of the heart is always 0. Heart level 0. So if a patient is laying down, everything's at the level of the heart. Hydrostatic pressure throughout is at 0. Once that patient stands up though, the heart is still at 0, but above the heart is negative, below the heart is positive, and it gets even more positive or more pressure as we move away from the heart. So number 1, would the measured pressure at the arm be more accurate in a patient laying down or standing? What about a pressure on the leg, and why? Number 2, describe how the movement of the diaphragm affects pressure in the thorax and the abdomen, and what happens to venous flow from legs and arms. And number 3, what questions do you have about this lecture?